Good afternoon. For those perhaps who weren't here in the morning session when I gave my first talk, my name is Martin Ellis. I'm a hematologist with an interest in myeloproliferative neoplasms, and I've been asked to talk this afternoon on the topic of management of symptoms in myeloproliferative neoplasm patients, which is the theme and the subject of the current session. So I think that the groundwork has been laid very well for me by the previous two excellent talks that we heard. By way of introduction and summary, I'll just mention that we spent a lot of time this morning speaking about the WHO, speaking about the diagnostic criteria, speaking about the real technical elements. But as has been mentioned before, we need to put the patient in the center. The patient comes to us with a baseline health profile, which includes comorbidities, aging patients, we mentioned that, medications that patients are taking. That's how they start out. We then diagnose their MPN, and we expose them, or they're exposed to all of these different risk factors that occur because this is a multifactorial disease, as we've mentioned, the vascular events that can occur that can certainly impact on quality of life and symptoms, the progression when these diseases turn into something that's more aggressive than the chronic phase of the disease, be it myelofibrosis or acute myeloid leukemia. We've seen something about the MPN symptom scoring, which I'll return to a little later on. The most symptomatic patients tend to be those with MF, followed by PV, followed by ET. We now have good numerical data to support that and to help guide us when we're treating patients with these different formulations of what perhaps, as we ended off this morning, is really the same disease, these molecularly characterized MPNs, which sometimes change between the various headings that we put them under. Certainly, we try to treat these symptoms when they arise, and we'll discuss the treatment, not entirely successfully, unfortunately, to this point. The symptoms of splenomegaly have been mentioned. These are typically mechanical symptoms, which I'll refer to once more. And an interesting point that should be made, and has only been recently realized, is that one would intuitively think that the bigger the spleen, the more symptoms the patients have from their spleen, directly from the spleen, but that's not necessarily the case. Sometimes people with only marginally or moderately enlarged spleens can have more symptoms than patients with very large spleens. Exactly why this is uncertain. There are theories, but it's an important thing to acknowledge that a patient with not a very large spleen can have a very symptomatic spleen. And then finally, symptoms relating to the abnormalities of the blood counts. We mentioned at the end of the talk about anemia. This is a particular problem in myelofibrosis patients who are dependent on treatment in a large proportion, including blood transfusions as the only option for treating anemia. You have seen this slide before from Ruben Messer, and I'll just show it to again emphasize that there's a wheel that's turning over here, and really one thing is feeding into another. So we have the inflammatory component of myeloproliferation, which was mentioned previously, and this is something that's becoming extremely important to understand. This, in fact, may be one of the main drivers of the splenomegaly that occurs. We're not exactly sure why patients with myeloproliferative neoplasms have an enlarged spleen. There's an element of extramedullary hematopoiesis, which I mentioned this morning as being the feature of cells in the body or organs in the body that are not the bone marrow making blood, extramedullary hematopoiesis. But certainly when we remove the spleens of patients with MPNs, we see a tremendous inflammatory component in the spleen itself. And patients on Ruxolitinib who have sometimes a marked decrease in the spleen size, the reason that is happening is because Ruxolitinib is a very, very potent anti-inflammatory. So inflammation is important not only for the symptoms that these patients have as a result of chronic inflammation, but possibly for the very large spleens that some of these patients have as well. I showed this slide very briefly this morning, and I'm happy to spend 1 or 2 more minutes on it because I think this really shows us the interactions between these two components. Again, we mentioned extensively that really what's important to understand is this JAK-STAT pathway, which is activated either by the JAK mutation or by the c-MAPL mutation, or now we know as well by the calreticulin mutation. So all of those driver mutations activate the signal transduction pathway. In addition to just simply increasing hematopoiesis, what this does over here with the leukocytosis and thrombocytosis, what this does is in some way cross-talk together with this inflammatory state over here, which is mediated by cytokines, those chemicals that we mentioned, that somehow are released. We don't know how. Hopefully our further research will be able to elucidate that and explain to us exactly what's happening. But the output, the end result, is this list of about 20 different chemical substances, which each one in and of themselves, if it were injected into our veins, would make us feel like we've had the worst flu we've ever had in our lives. And people with myeloproliferative neoplasms, specifically those with a strong inflammatory component like myelofibrosis, like severe polycythemia vera, they walk around constantly with elevated levels of 1, 2, 10, 15 of these cytokines. So it's understandable in that case why a lot of these patients will complain of severe fatigue, lassitude, headache, difficulty in concentration, just like when you've had that very bad flu. And this is what's causing it over here. So we sort of understand a little bit about what is happening on a biological level. And to translate this into clinical practice, I think really we have to acknowledge Ruben Mesa and his group, then from the Mayo Clinic in Scottsdale. He was really the first to try and quantify all of this in what's called the Symptom Assessment Form, which he developed, and it's undergone a number of iterations. The one that's commonly used now is the so-called MPN 10 with the 10 items that's meant to be used for follow-up, and there's a more extensive one that's used at the time of diagnosis. And these are, well, I'll show you some results of publications regarding this. Basically, these symptoms are analyzed in groups, those that are vascular symptoms, the constitutional symptoms like weight loss, fatigue, sweating, and so forth. There are 4 items which relate to the size, to symptoms related to the spleen. That can be abdominal pain, discomfort, early satiety, weight loss. And then there, in the more extensive version of this SAF, there are 9 items from the brief fatigue inventory, which is not specific to myeloproliferative neoplasms, but it's included. And as you can see here, we're international. So we'll mention that this has been translated into a number of languages, and there are a couple of languages that don't appear here. It's just recently been translated into Arabic, so that's available as well. For those of you who haven't seen the form, this is what it looks like. And again, you can refer to it in the slide pack which you receive afterwards. Here is a question that you're meant to answer regarding the past 24 hours. All of the rest are the past week. And the symptoms over here, some of them may be fairly general symptoms like inactivity, problems with concentration. I guess anyone would answer those questions at some point is not getting a perfect score. But a lot of them are fairly specific to myeloproliferative neoplasms. And then you score this, and the patient can be objectively have his symptoms quantified on an ongoing basis. You saw part of the slide on the previous, in the previous talk. And I think that what's important to notice in this slide as well is that if you just look, it's fatigue that takes it for all 3 patients. And what I want to point out over here is for patients with ET, they're very well represented here. So ET is a symptomatic disease as well. It's the blue bar. It keeps on appearing. It is the baby brother. Myelofibrosis in the green is always the winner. ET is always the loser in numerical terms, but in life perhaps it's the other way around. But it's important to realize that even our ET patients have a very, very significant burden of symptoms across the board over here in the results of this MPN scoring system that we use. Some new facts that have also been mentioned earlier, some of them came out of the landmark study, and that is, I think it's important to realize as well that unfortunately things tend to get worse the longer the disease is present. So symptoms tend to trend or correlate with the duration of disease. Insomnia has not been well recognized until now as a symptom, and there's now work ongoing to try and understand exactly what is causing the insomnia or how we can characterize that insomnia. Are there frequent awakenings? Are there disturbances in REM and non-REM sleep? And this hopefully will be helpful to a large number of patients. And we've heard about the gender inequality of symptoms as well. So for the rest of the talk, I'd really like to focus on a patient, put the patient in the center, and just take you on a patient's journey over here. I thought I'd just bring one case so we can focus on that. This is a 46-year-old gentleman. He's a patient of mine. He works in an office. He works in shared office space, and that might become relevant later. And I saw him first about 9 years ago, and I saw him last 2 days ago. So he was referred to me because he'd been complaining at his primary care physician of fatigue, headache, tinnitus, which is ringing in the ears, and itch, which is pruritus. His family physician did a workup which showed that the hematocrit was elevated, so was the hemoglobin, the 3-to-1 ratio. The mean cell volume, which is a number that you get on the complete blood count, was low. That indicates that the red blood cells are small in size. And that has a number of implications. The first thing that a physician should think about when he sees a low mean cell volume is that the patient may be deficient in iron, unless he happens to be working in the Mediterranean basin, where he should perhaps think that the patient may have a form of anemia called thalassemia. But clearly, a man with a hemoglobin of 19 grams per deciliter does not have thalassemia, which presents with anemia, and one would consider this patient perhaps to have iron deficiency. I will come back to this point a little later on. It may be of some interest in general in the context of polycythemia vera. And his platelet count was elevated, 500,000. This is how I got the patient. I think everybody in the room could probably make the diagnosis in about 20 seconds, so it's not very complicated. However, just going back to the point that was raised before, the GP, how long did this gentleman complain of fatigue, headache, non-specific symptoms? The answer is I don't know. I don't remember. But I suspect that he complained for more than 2 days, and I wouldn't be surprised if this diagnosis wasn't apparent somewhat earlier than it was actually made. As a hematologist who receives patients who've been worked up already to some extent by their family physician, our job is relatively easy diagnostically, not always, but sometimes, certainly in this case. And this slide reminds me to talk again about the importance of getting the message out to primary care physicians that not everybody with a headache just has a headache. They may have an MPN which is causing their headache. So as you figured out, this patient has polycythemia vera, straightforward diagnosis based on the system I showed you this morning. He was 46 at the time, so the standard of care for him would be phlebotomy and aspirin, as we mentioned this morning as well. He'd be considered a low risk for a thrombotic event, and this is the preferred treatment for him. So over the next 4 years, we got to know each other, and what actually happened was that he complained of worsening pruritus. Terrible. He also used to feel very, very hot. He would sweat a lot. My part of Israel has a very hot and humid climate for about 7 or 8 months of the year, and this was very tiresome and troubling for him. He worked out his own system for dealing with this at the workplace, because he would be hot and sweaty and uncomfortable and red and plethoric and feel terrible the whole day, and he had to sit under the air conditioner, have the air conditioner blowing cold air on him all the time. His workmates used to come to work in thick jackets, and he would sit under the air conditioning. We'll talk about alleviation of symptoms and how patients deal with that. That was his system. He was feeling worse instead of feeling better. The reason for that was that he developed iron deficiency, and I come back to that low MCV. Iron deficiency in polycythemia vera patients is common. In fact, it's a subject that we're studying now in our working group. It's common at the presentation of polycythemia vera, and it's even more common during the course of polycythemia vera, for obvious reasons, perhaps. At the presentation of polycythemia vera, one can be iron deficient because iron is an essential atom which hemoglobin needs in order to be formed. So hemoglobin has one molecule of hemoglobin has one atom of iron at its core, and patients with polycythemia vera are making a high number of red cells, so they're using a lot of iron to make a lot of hemoglobin. This is abnormal, of course, but it's basically depleting them. They're depleting themselves of iron stores just by virtue of their increased erythropoiesis. Then we start treating the patients, and we do phlebotomies. Now, the way that phlebotomy works, apart from immediately reducing the hematocrit, which can get people out of thrombotic problems and help them with headaches and dizziness and so forth, but ultimately, chronic phlebotomy is meant to induce a state of iron deficiency. That is why we do it. So eventually, the patient becomes iron deficient, and even though JAK2 is trying to cause erythropoiesis, well, hemoglobin cannot be synthesized because the elements needed to make hemoglobin, at least one of them, the iron, is absent from the body, and therefore the hemoglobin tends to stabilize. So we actually induce iron deficiency in patients, those that don't have iron deficiency to start off with. We weren't perhaps aware enough of the fact that iron deficiency in itself is a symptomatic condition. Even if iron deficiency does not lead to anemia, as is certainly the case in polycythemia, iron is necessary not only for the synthesis of hemoglobin, but for other proteins in the body. And iron deficiency itself can cause almost all of the symptoms that you see on the symptom assessment score, from inattention, inactivity, lassitude, sleep deprivation, muscle pains, and on and on. He developed weight loss. His platelet count started going up. We mentioned in the thrombocytosis section this morning that secondary thrombocytosis can be caused by iron deficiency. I think I slipped that in quickly. In young women, particularly women who have menstrual periods and who have been pregnant recently, iron deficiency is extremely common, and a lot of these young women will have thrombocytosis. So when we see a young woman with thrombocytosis, we first exclude iron deficiency before we think of ET. We've made him iron deficient, his platelet count is going up. We mentioned that platelet counts are starting to become important risk factors for thrombosis in polycythemia vera as well, so this might not be a good thing. And while all of this is happening, his phlebotomy requirement is increasing. So my theory before of becoming iron deficient being something that you can actually be thankful for because it'll reduce your phlebotomy requirement, in his case, that wasn't happening, which means that his disease is very, very proliferative and is becoming more proliferative as time goes on. So just to divert now and talk a little bit about the management of the disease symptoms, so we can sort of focus on what the patient can do and how we can perhaps advise them, and then what the physician should be doing. So in terms of pruritus, which is a very problematical symptom in polycythemia vera, this is worsened by sun, it's worsened by bathing, as we know, particularly hot bathing or exposure to hot water. It's called in a lot of circles aquagenic pruritus because it's stimulated by water. So one should rather recommend showering than bathing, showering with cold water. Patients have told me that when they turn the faucet on full go, it's much more disturbing to them than if they just have a light patter of water. So I'm not sure if that's accurate or not, but certainly some patients seem to use that as a way of avoiding this. And then the exposure to a cool ambient temperature may help pruritus. It certainly did in my patient, and I think that makes some kind of sense, at least to me. And these would be things that I would try and encourage patients to try to minimize this symptom of pruritus. In terms of, and I'll talk about medical treatment in one of the next slides. In terms of other symptoms that patients with polycythemia may have, these microvascular types of symptoms, headache, tinnitus, dizziness. Here, hematocrit control is very important, and we mentioned that this morning as well. The goal is 45% hematocrit, but some patients will feel much better with 42 and even 40% hematocrit. They'll have a symptomatic improvement, even though they're within the guidelines and they're probably not going to have a thrombotic event. They'll feel better with a lower hematocrit, even though you're within your guideline recommendations if you stop at 45. So that we try and do as well for some patients and see if lowering the hematocrit even more will resolve some of the symptoms that patients are having. Aspirin, I think we heard before that aspirin is a very effective treatment for erythromelalgia, for the tingling and the painful sensation in the tips of the digits, and that certainly needs to be used. Increasing the dose of aspirin might be a technique that can be used for patients who don't get response to the standard 100 milligrams a day. And there was literature a few years ago, which hasn't really been featured recently, about using aspirin twice a day. The way that aspirin works is that it inhibits platelet function, and in actual fact, platelets are produced at a very rapid rate in the myeloproliferative neoplasms, and it could be that if you expose the patient to aspirin once a day, the platelets that are made later on in the day, so to speak, that do not have the aspirin effect, because aspirin has been metabolized by the time those new platelets have been produced, and they're only going to see aspirin again tomorrow morning. So there are proponents of giving aspirin twice a day to almost everybody, this is certainly something that I do if I have patients who are on aspirin and are not having relief of microvascular symptoms. Sometimes increasing the dose from 100 to around 300 milligrams is also helpful. Now, what about the iron replacement? Because iron replacement is something that you would do intuitively in someone who has iron deficiency under normal circumstances. It certainly improves symptoms. However, you can't do that in polycythemia vera, because if you replace iron injudiciously, patients' hemoglobin and hematocrit will rocket up and you'll be back to where you started. So the recommendation here is to do it very, very carefully and assess frequently what's happening to the hematocrit, and also, if you can, what's happening to the patient's symptoms. The times when I have done this, I've either had tremendous success or tremendous disaster with the patients managing to be relieved of some symptoms, and then I've had patients whose hemoglobin has gone up to 20 and their hematocrit up to 60, and they've needed repeated phlebotomies to get back to where they were before. So it's not a particularly good thing to do unless you're ready to live with the consequences and phlebotomize frequently. So back to our case. At this point, after about 4 or so years, he's very proliferative. He needed hydroxyurea added to his phlebotomy. He was having phlebotomies like every 10 days. It was unacceptable to him. He made these lifestyle changes that he told me about, that I suggested to him. We tried some drug therapy for his itch. Antihistamines are standard drugs that are used for itch, and the antidepressant group of drugs called the SSRIs, the founding member of that group was Prozac, can be useful for itch. We tried these, of course. During all this period, his blood counts were very well controlled, and as I said this morning, my main job as a physician was achieved. He had no thrombosis, he had no bleeding, so things are great as far as I'm concerned, but as far as he's concerned, life wasn't so great. 8 years on, I'm perhaps being a little self-deprecating. Of course, we spent a lot of time discussing his symptoms and trying to solve them, but just to make the point that his main complications of an MPN were dealt with very, very substantially and effectively, but these subtleties that only in the last few years we've come to recognize and to realize that are really there, that's what was bothering him. And then the totally unacceptable happened not so long ago. He started to develop a series of localized skin cancers which were on his face. He unfortunately did not give me permission to photograph his face. These were a combination of squamous cell carcinomas and basal cell carcinomas, which were fortunately for him all superficial and could be easily resected by dermatologists and plastic surgeons. However, there were multiple, they were recurrent. Squamous cell carcinomas can be dangerous if they invade, they can metastasize, unlike basal cell carcinomas, which are only locally invasive. Both of those skin cancers have an increased incidence in MPNs in general, and as a result of hydroxyurea in particular. So one had to start considering the fact that he might be having now intolerance to hydroxyurea. And then the final straw was when he developed the dreaded skin ulcers on the side of his ankle over here. This is already in a healing phase, and something which I had not seen before. Similar ulcers developed on his hands as well, with discoloration of his fingers, with appearance that is akin to vitiligo, which is loss of pigmentation of his skin, and you can see some more ulcers on his knuckles over here. This is an office worker, he's not a manual worker. There was no reason for him to have these findings on his skin. So this basically is an absolute indication to stop hydroxyurea. Here's hydroxyurea intolerance. We look at it in two terms: hematologic intolerance and non-hematologic intolerance. Basically, hematologic intolerance means low blood counts, leukopenia, anemia or thrombocytopenia that's not acceptable while the patient is on a particular dose of hydroxyurea. The non-hematologic toxicities are listed over here. Really, leg ulcers comes in at number 1. This occurs in perhaps 4 to 6% of patients, and it's an absolute indication to stop hydroxyurea. In my experience, this is underdiagnosed even by dermatologists. A lot of dermatologists where I work are not aware of the fact that hydroxyurea can cause this. I've had patients who've developed leg ulcers between interim visits with me, which may be, say, every 4 to 6 months, and for the last 2 or 3 months they tell me the dermatologist has been giving them a variety of treatments for an ulcer and they're still on their hydroxyurea. So we're trying to get the message out to dermatologists that hydroxyurea plus ulcer equals stop hydroxyurea. There's this increased tendency to skin cancers that I mentioned. A lot of patients will complain of a painful mouth, tongue, mucous membranes of the mouth, basically, and there can be some discoloration as well, which I'll show you. Hydroxyurea can cause ill-defined abdominal discomfort. It's very, very rarely associated with a form of lung disease called interstitial lung disease, and then it's well known that hydroxyurea can cause fever, and sometimes it's a first dose effect where after taking 1 hydroxy tablet, a patient can have a 39 degrees Celsius temperature. I always warn patients about that as well, because once I didn't, and we had a patient rush to the emergency room because they had fever the day they started taking hydroxyurea, which is a pity. This is another patient of mine who's on hydroxyurea, and you can see the discoloration over here on the sides of her tongues, and you can see here, I'm not sure if it's projecting well, but you can see this discoloration that she has here in the skin. These are the mucous membranes and the nails. The mucous membranes and the nails are really the same tissue origin as the skin. So the skin changes, the mucous membrane, the nail changes, all go together. This is painless. This particular patient, who's of Indian origin, decided to continue with hydroxyurea. She was happy with the treatment result, and she was quite happy to put up with this odd side effect that she had developed. What happens when a patient has hydroxyurea intolerance? We have to move on to other lines of treatment. We mentioned busulfan very briefly this morning. This is a drug that is leukemogenic. It will cause leukemia, so we reserve it for the very old patients where the risk of leukemia is low, considering that their lifespan is considered to be very short. We mentioned interferon, a very, very active and effective drug in myeloproliferative neoplasms in general and in polycythemia vera in particular. There's a preparation called Pegylated interferon, where it's interferon with a molecule called PEG, polyethylene glycol, which has been attached to the main interferon molecule. This gives it a long half-life. Unfortunately, this is not widely available. In fact, in most countries, it's not available. And this would be a good place for a little bit of patient advocacy. To get Pegylated interferon licensed for MPNs would be a service to mankind. Interferon causes flu-like symptoms. In my experience, you can deal with these fairly effectively with dose modifying the patients and starting with a very low dose and building the dose up slowly rather than starting with the recommended dose. But there are numerous other side effects which we don't have time to go into, including depression, thyroid abnormalities, and so forth. The new kid on the block is the Jakafi, the Ruxolitinib, which is now licensed for hydroxyurea-resistant or intolerant polycythemia vera, as we said this morning. But we don't want to drop the ball, and we have to recognize that even Ruxolitinib has side effects, and infection is an important one that we're starting to see more and more and be cognizant of it and looking out for it. It's dangerous to stop Ruxolitinib all at once. You need to taper the dose rather than stopping abruptly. There's an incidence of skin cancer as well with this drug, and there's this strange phenomenon of increased lipids, cholesterol and triglycerides, which can occur soon after starting Ruxolitinib. Back to the case. So he has to have his hydroxyurea stopped. Phlebotomy is not a good option for him. He needs interferon, which we started, and he's tolerated it well so far over the last few months. He had tremendous improvement in his skin lesions. His ulcers healed, and he's had no new cancers. He was developing a new skin cancer perhaps once a month or once every 2 months. He had to have one removed. In the last, I think, 8 or 9 months since he's been on interferon, he's had none at all. Interferon is also very successful at moderating the myeloproliferative aspect of his PV, and he has had, I think, no phlebotomies for the last 4 to 6 months. Unfortunately, pruritus is not improved. He has a big, big spleen, and his symptom assessment score has actually remained unchanged. Some of his symptoms have gotten better, some have gotten worse, and his overall score is unchanged. So the lessons that I learned from this patient, and I think this has been mentioned before, it's just worth, I think, repeating it, and that is that sometimes there'll be a little bit of dissonance between the physician's view of a successful treatment, the patient doesn't have any major adverse events, versus the patient's view of a successful treatment plan, which is him feeling well and functioning fully. And we've seen already how these things can be malaligned, how they are. We've seen the results of that study. And really, I think that our challenge, along with your challenge, is aligning these things. And clearly, patients are happy that they're not having major adverse events, but we need to make sure that they understand that we're doing everything that we can as a community to help them live a full and functional life. So where do we see the opportunities to try and improve on this? And I think this has also been mentioned in this session, and that's what it's all about, and that's looking at the patient-reported outcomes. This is a new piece of jargon that's found its way into clinical research, and the contemporary clinical trials, as with the landmark study, would look at patient-reported outcomes, not the physicians reporting on what they think is happening with the patients, but the patients themselves giving the input. They're the ones providing the data, not the clinical trialist necessarily. So that will be in the sense of doing that in clinical trials in a very, very organized, systematic way. That'll give us very important information. And the corollary of that in daily clinical practice is using the MPN scoring assessment form in a routine and an organized fashion. It's something that we've started doing, and a lot of our centers are starting to do that. And I think that'll give us a good insight into an individual patient and how he's track him over time and see how he's doing. I'm a big fan of patient registries, and we just started ours the second half of 2017. There are a number of national patient registries, and there are some international collaborative efforts that are underway. These collect somewhere in the region of perhaps between 1,000 and 2,000 of each of the MPNs. We said this morning how rare these diseases are, and we mentioned it again this afternoon. And this is a fantastic repository of data that can be accumulated, and we can learn a lot about patients, about what happens to them, both clinically, biologically, and also psychosocially from such registries. And perhaps if we're thinking of ways in which the entire community can work together, that will be something that I would encourage certainly this group of advocates to consider going back home and talking to their local working groups about. I think this is a very, very potent tool. A lot of what we know about hydroxyurea intolerance and a lot about what we know about the consequences for the patients of hydroxyurea intolerance in terms of disease progression comes from the Spanish National Registry. We owe them a debt of gratitude. Otherwise, it was information that was not captured anywhere, and that's really the only data source that we have for that particular clinical question. Clearly, it's important outreach. We have so many ways that we can do it now. The social media are abundant, and we can use these tools for our patients' best advantage. Thank you very much.